Hi, everybody. So I'm Tony Bariant, and I am the leader for the HLAA Mission Chapter. And in Mission, I'm located in Laguna Woods. The chapter is not currently meeting in person. I really don't know what the status of in-person meetings is going to be. I know that, just so you know, that the Hearing Well Club has merged with the Hearing Loss Association Mission Viejo chapter. So we are all one. And but that doesn't mean I can't have meetings for the Mission Viejo chapter in Laguna Woods, which if we have any, that's where it'll be. But currently, the meeting space is not available to me. There's certain meetings that have started, but it's not in the clubhouse where we have a hearing loop and all of that. So probably not going to be until the first of the year. So we're already in September. We're probably going to go through the fall and part of the winter just doing Zoom meetings. Okay, Alan Katsura. So Alan, you wave your hand. Alan is my technical support, and if anything should happen to me, you know, I don't know if you noticed, I'm not in my usual place. I am visiting my mother. I'm in San Diego. It's wonderful because when you're on Zoom, you can be from anywhere. So so I'm in her office, and you know, the dog may bark. My mother might walk in and join us. So let's just see what surprises we have. Alan Katsura is a technical support. If you can use the chat feature, you can send him a chat message if you have an issue with anything. I'd like you to use the raise hand feature if you have a question. So there's a toolbar at the bottom of your computer if you're on a desktop or a laptop. If you're on iPad, I don't have specific instructions for you about that, but there is a place where you go and get reactions, and there's a place where you can raise your hand. And that puts your name up front, and I see you, and I will call on you in order. All right, so there's that. And if do you need some assistance right now? Does anybody need assistance on how to find shut up. How to find your toolbar, or how to find the reactions? Does anybody need help with that? Okay. You know, we've been doing this for well over a year, and so many of you have learned, just like I have learned how to be a hostess, you've learned how to figure out being a participant. So that's great. We're all getting experience. Okay, I just have a poll that I want to take, and I'm going to launch this poll, and I'm just going to give you a minute or so to answer the question. And the question is, how did you discover this meeting? So I'm going to launch this. Oh, wait a minute, hold on just a second here. Uh-oh. Yo, I messed something. Okay, here you go. So how did you discover this meeting? I'm on your email list. I found out about you on Facebook. I found about you about Twitter, or I found out about you or about this meeting from my state, HLA state or chapter. I'm just curious to see if anybody is finding us on Facebook.
I found out about it from another member of the local organization.
Okay, Alan. What's happening here? Okay. Okay, so we've got 88% of you. There's like 3 more people that could answer that. Okay, that's it. This is an interesting question. I'm going to share the results. So this is how you answered. So the majority of you are on my email list. And there's 5 people that found out from their state or chapter. So thank you all for participating in that. The Hearing Loss Association of America is a national nonprofit organization. The chapter, the Mission Viejo chapter, is also nonprofit, and there are no, on the chapter level, there are no employees. We're all volunteers. We have a very small staff. We have a treasurer who is with us today. He's on the call. We have Jeff Chess, and we have a vice president, Judy Mandel. She's not going to be with us today. And George Gross is with us today, and he's my program director. So he helps get the calendar organized for the year. I do want to talk about HLAA membership. It's an annual membership. It's $45 for an individual. You get a subscription to Hearing Life magazine. HLAA supports advocacy for 8 million people in the United States, and provides educational and entertaining webinars on a regular basis. You can find that information on their website. Alan, you might want to put this in the chat for me, please. It's hearingloss.org is the website. They do annual conventions, especially now, hopefully with COVID being handled. Next year, we'll have an in-person meeting. For 2 years now, they've had an online convention, which I thought was very successful. Very educational, a lot of presenters. And I want to talk to you too about the chapter has expenses, and appreciate your donations. The chapter website is hlaamv.org. There's a donate button. You have the opportunity to do a reoccurring donation. Like if you could do $3 a month, that would be wonderful, or $5 a month. Doesn't have to be big, just something that is regular would be very helpful for the expenses that we have. Okay, and here's a disclaimer. The Hearing Loss Association of America believes that information about products and services that could benefit people with hearing loss should be made available to consumers about their hearing health care. As such, reference to specific products, services, organizations, or claims made in advertisements or sponsorships through HLAA, including but not limited to Zoom meetings or presentations of HLA-MV. So we don't advertise, we don't recommend one company or product over another. It's just, we're just providing information. Okay, I'm going to tell you about a couple of meetings coming up. The Los Angeles chapter has a meeting that I think would be really wonderful if you could attend. I do have it listed under events on the Mission Viejo chapter website. It's Catherine Bolton the title is How I Lost My Hearing and Found My Life Again. She is a well-known author in the hearing loss community, and she brings her personal experience and will answer questions. So that's going to be September the 25th at 10 a.m. It's a Zoom meeting. And that information again, and the link to register is on the Mission Viejo chapter website. Our meeting in, this is September, in October is, it's October the 12th, if you want to put that in your calendar. This is going to be a very interesting meeting. 11 a.m. Dr. Michelle Kapalowitz, PhD, she's an assistant specialist in the Center for Hearing Research lab at University of California, Irvine. And her topic is going to be talking about a new treatment that may be available. She's been researching it. That involves the auditory processing. And so she's finding that that with this treatment, it actually improves auditory processing. So I'll let her do all the explaining about it. Again, she's a research specialist, Dr. Kapalowitz, UCI Irvine. She has presented before on tinnitus. She has a wonderful presentation on tinnitus that you can find the recording of that on the YouTube channel, the Mission Viejo chapter YouTube channel. And let's see if I have that here to give you. Okay, so in the chat box, I just gave you the link to the YouTube channel. So everything that's recorded is presented there. Okay, I'm sort of done with everything I wanted to do. I want to introduce to you Dr. Ashley Balaker, MD, Board Certified Otolaryngologist. That's a big word. It took me a long time to learn how to say it. And she specializes in hearing and balance orders for both adults and children. And she attended Keck, USC School of Medicine, and she completed her residency at the UCLA Medical Center. So now you do cochlear implant surgery. So she didn't list that in her bio, but she does participate. So she is a surgeon, and I'm gonna want you to unmute yourself, Dr. Balaker, and welcome.
Hi, thank you, Tony. It's nice to see everybody. As Tony mentioned, I do perform cochlear implant surgery, primarily on adults. I do perform some pediatric surgeries, but most of my cochlear implant practice is actually adult patients. So I'm just going to share my screen here to get the presentation going. Okay. And then, you know, my practice is located in both Irvine, Laguna Hills, and Newport Beach. Those are the offices that I see patients at. Our larger practice also has an office in Mission Viejo, which is where a lot of the testing for the cochlear implant candidates is done. And so patients oftentimes will be seen at that office as well. So just to get started, the topic today is we're going to be talking about cochlear implants for adults and who is a good candidate for this and some things to take into consideration if you are considering a cochlear implant or if somebody you know is. Just an overview of what I'll cover. I'll start out with just some basics on how hearing works, different treatments for hearing loss, and then we'll talk more specifically about what a cochlear implant actually is, what the criteria for adults is to be a candidate for that. I'll talk some about the details of the surgery and the risks involved. And from a patient perspective, kind of when you would want to start even considering a cochlear implant. We'll talk some about post-implant care and rehabilitation and just some long-term considerations for patients. And then I want to have some time at the end for questions. So, some of the stuff in the beginning, I may go through a little more quickly just so we have more time for questions at the end. But please, feel free to use the chat feature if questions arise when we do the question time. So this is a very complicated picture, but generally hearing kind of has two components to it. There's the actual mechanical sound wave that comes in through our ear canal. And then we have the eardrum. The eardrum vibrates, and that sound vibration is transmitted through these three middle ear bones. That entire portion of the hearing is really a mechanical process. Once the sound wave transitions from the hearing bones in the middle ear to the cochlea, it is transformed into an electrical signal. And that's really where cochlear implants come into play, because once it's an electrical signal, that can be treated with cochlear implantation. We talk about with hearing, binaural versus unilateral hearing, and this comes up a lot with cochlear implants. It is obviously beneficial to have two ears that are hearing, primarily for sound localization and also for performance in background noise. With only unilateral hearing, it's very difficult to localize where sound is coming from, which does carry some risks with it when you can't perceive where a sound is coming from. And in general, patients will not perform very well when there's background noise present if you only have one ear that is functioning. And they've done studies that show that even if that other ear has perfect hearing, your understanding will go from about 90% to 60% if there's background noise present. So having two ears functioning and aided really does give a lot of benefits for social situations in particular. And then we talk about the connection between the ear and the brain. Once that sound signal becomes the electrical signal in the cochlea, that's where those hair cells function, and those pick up the sound and transmit it to the brain through the auditory nerve. One interesting thing about the cochlea is that the hair cells are actually arranged in a tone map where certain frequencies are in one part of the cochlea. The higher frequencies are at the base of the cochlea, which is shaped like a snail shell, and the more bass tones are at the tip of the cochlea. And that discovery was very important for cochlear implants because the electrode we use is also programmed based on that tone map. So they can stimulate different areas of the cochlea to produce different tones. And then the auditory nerve picks up that signal and sends it to the brain, the auditory cortex. If your auditory nerve is not stimulated over long periods of time, you will actually lose nerve cells in that nerve. And we see that a lot with patients. If they haven't been using hearing aids for a long time, they will actually lose some neurons there and they will have more difficulty understanding speech and with the clarity of sound. So the auditory nerve, it's very important to stimulate it and the auditory cortex to preserve those nerve cells. And in many patients with hearing loss, we actually see that in the auditory cortex, the brain may actually recruit other areas of the brain to help with sound processing when there's a hearing loss present. And so there's been a lot of research lately looking at that, how that affects cognition and how your brain functions if you're having to utilize other areas of the brain to interpret sound and make sense of speech that can kind of put a burden on the rest of the part of the brain that processes higher level cognitive functions. And so there's a lot of research on that right now with regards to dementia and onset of dementia and how that may be related to hearing loss. So with hearing loss, there's really the two main types. The first type is conductive hearing loss, which is affecting that mechanical portion of the ear. So that's stuff like earwax, water being trapped in your ear, having fluid behind your eardrum from a cold, your ear is clogging after a plane flight, and then of course infections, perforations in the eardrum, any sort of trauma to the ear can damage that mechanical portion. And then otosclerosis is a particular condition where the stapes bone, which is the smallest middle ear bone, becomes progressively fixed over time. Some calcium deposits form around that and it can't vibrate properly. So all of those are conductive problems. Conductive problems are typically treated with either medication or surgery and oftentimes can be fixed. Cochlear implants are not for mechanical problems. So we do not treat any of these problems in particular with a cochlear implant. These are treated with other options. And that's something that we can determine on a hearing test. That difference between conductive hearing loss and sensory neural hearing loss is one of the main things we're looking at on a hearing test. So sensory neural hearing loss is an electrical problem, and that's occurring in the cochlea. That's a picture of the cochlea. This picture actually has a cochlear implant electrode in it. You can kind of see that snaking around that snail shell type structure there. And so when we have loss of these hair cells in the cochlea, then a cochlear implant sometimes can treat that if a hearing aid is no longer adequate. So things like noise exposure over time can damage those hair cells. Aging is probably the #1 reason that we see people need hearing aids or need a cochlear implant over time. And that is heavily influenced by our genetics as to what age we start to lose hearing and how rapidly that progresses. Certain viral infections can damage this type of hearing. I see patients all the time who lose hearing suddenly from a viral infection. And we see that with many cold viruses. We have seen that with the current COVID pandemic. Some patients lose hearing with their COVID infections. And that's affecting the cochlea. That's a neural hearing loss. And then certain medications have been known to damage those hair cells, autoimmune diseases, and then a Meniere's disease is a disease of the inner ear where there's a fluid regulation problem, and that over time can cause hearing loss and damage those hair cells. So all of these conditions can cause progressive hearing loss, and if the hearing loss gets bad enough and the hearing aid is no longer helpful, a cochlear implant is sometimes considered. Now, these are electrical problems that we really can't treat with a cochlear implant. People who have damage to the auditory nerve itself from a tumor, for example, the cochlear implant is in the cochlea and the nerve connects the cochlea to the brain. So if that pathway between the cochlea and the brain is damaged, the cochlear implant can't function. So patients who lose hearing because they had a brain tumor removed or a stroke, sometimes multiple sclerosis can cause some of these problems. They're not great candidates for a cochlear implant. They're unlikely to do well with the implant. So presbycusis, which is age-related hearing loss, like I said, is probably the most common reason that I see patients presenting for a cochlear implant. It usually affects the high frequencies first, and then over time you see that go down. A lot of times the lower frequencies may be preserved. And a lot of patients don't realize, even patients who have pretty good low frequency hearing, if you lose a lot of higher frequency hearing, sometimes those patients can be a candidate for a cochlear implant. And there's techniques we can use to actually preserve the natural low frequency hearing when we put in the implant. And that's gotten better over time as the implants have become less traumatic and thinner electrodes. All of these advances have made that possible. So treatments for hearing loss, we kind of talked about this. The conductive hearing loss, we usually treat with medication or surgery. You can treat conductive hearing loss with a hearing aid as well by amplifying the sound to overcome that obstruction. And then some bone conduction implants, which are a different type of implant than a cochlear implant. Sensory neural hearing loss, we usually treat with hearing aids. And then if hearing aids are no longer adequate or effective enough, we consider cochlear implantation. And for cochlear implants, just to give you an idea of what those look like, these are kind of the two most common models that we see currently. This type has been around for a long time, where you wear the processor on the ear and then you have a magnet. This magnet couples to the internal implant, and that's how it sends the information from the processor to the internal implant. More recently, there have been developments of a unibody type of processor, which has both the processor and the magnet in a single piece. And these are becoming a little more popular for some patients. I have to say, especially with having to wear masks and eyeglasses and other things on your ear, our ears are holding a lot of stuff these days. And some patients really like having the processors where they can get it off of their ear. So what is a cochlear implant? A lot of patients do not realize that the cochlear implant is a two-part system. I have a lot of patients who come in and they don't realize that there is still an outer component. It's not completely implanted. There's an implant, which is what is placed during surgery. And that on this diagram, you can kind of see here on the cutaway. And that has a body of the implant and then the electrode down here that goes into the cochlea. And that's what we put in during surgery. The external processor is what I was showing you on those other pictures. That's what sits on the ear, and then it communicates through a magnetic coupling device. And so that entire system is what we are talking about when we talk about a cochlear implant. The internal implant does not do anything without the external processor. The processor is what picks up the sound. If you take your processor off, you're not going to be hearing anything. So when people, usually when they shower or go in the water, they're going to take off their outer processor, just like you would a hearing aid. But during that time, the internal implant is not being stimulated. So there are three main companies that make cochlear implants. Cochlear Americas, this is actually initially was founded in Australia. They're definitely the largest global market share, and especially in North America. These are the most common implant company that you'll see. They have recently partnered with Resound hearing aids to provide bimodal hearing for patients who have a cochlear implant in one ear, but are still using a hearing aid in the other ear. That type of hearing aid can communicate with the implant, and the sound processing can be done together to get a better performance in background noise. Medel is based in Austria, and actually these two companies, Cochlear and Medel, developed cochlear implants at the same time. They were actually two different researchers that were developing them concurrently, and they came out with implants around the same time in the 1970s. They have a very large presence in Europe, obviously, since they were based in, let me get this back going. Since they were developed first in Europe. Let's see, there we go. And then the last company is the Advanced Bionics. Great. Hopefully that's still sharing okay. Advanced Bionics is actually here in California. It was founded in 1993, and they've partnered with Phonak hearing aids. So you will sometimes see that they do the same thing as Cochlear does with Resound for the hearing aids.
Dr. Balaker, we still can't see your PowerPoint.
Oh, no. Okay. Thank you. Let me go back to Zoom and see if the sharing went off. the joys of technology. Okay.
There we go. We got it. Thank you.
Okay. Let's see. You. Okay. I think we're back on track now. So let's talk about the criteria, because this is very important for who could actually be a candidate for a cochlear implant. So current FDA guidelines are for the patient should have moderate to profound sensory neural hearing loss in both ears. The other component of that that's very important is that they're getting limited benefit from their hearing aids. The patient must have at least had a trial of hearing aids before being considered for a cochlear implant. And then the testing that is done for cochlear implants, part of that testing is actually done with hearing aids on to show, you know, whether they're able to perform with a hearing aid or not. And so those scores are defined by recognizing less than half of sentences in the potentially implanted ear and less than 60% in the opposite ear. And that testing is different than a regular hearing test. Many of you, I'm sure, have done hearing tests, and you know when you repeat back the words in a hearing test. This testing is done actually with complete sentences, and they test you both with hearing aids, without hearing aids. They also test you in background noise to show more of like a real world situation. And so that's what those percentages are based on. That type of testing is called a cochlear implant evaluation, and that's done with an audiologist. And that testing, it does take longer than a hearing test. So it's usually about an hour of testing with the audiologist. But that testing is very important, and we have to do that to show that a patient needs the cochlear implant as opposed to just a hearing aid. That's very important for insurance coverage as well, so that they will cover the implant. This audiogram that you see here just kind of gives you an idea of patients that fall in this yellow area on their hearing test. It gives us an idea of where we would want to see the hearing test results landing for considering a cochlear implant. Obviously, you still need that second component with regards to the word recognition scores. But as you can see here, you can have pretty good low frequency hearing and still be a cochlear implant candidate. It's really when you are losing hearing in these mid frequencies to the high frequencies, that has a big impact on your ability to understand human speech. And that's where we expect to see a lot of hearing loss if you're going to be a cochlear implant candidate. So as part of the preoperative assessment, when I'm seeing a patient in the office, there's really the two main components to that. They have to do the testing with the audiologist. That's that evaluation that I was talking about, where they do the tests. And they do that with the hearing aids as well as with background noise. My part of the evaluation is really the medical end of things, since I'm the surgeon. The audiologist does all the other testing. They do the programming. I'm the one who determines whether the patient would be appropriate for surgery, whether we can put the implant in based on their anatomy, and also their risk assessment for anesthesia is very important. So I always perform an ear exam in the office. I'm going to make sure there's no chronic infection, that there's no anatomical problems that would make it difficult to put an implant in. We generally do not recommend an implant if you have a hole in your eardrum, because that would expose part of the implant and make you more likely to get an infection. So sometimes we have to address some of those medical issues first, if some of those are present. I also perform a CT scan of the temporal bone. The temporal bone is the bone around your ear. And so we scan that area to make sure that the part of the bone where I need to go and also the anatomy of the cochlea itself is okay for implantation. Anesthesia risk. This surgery, it's about a 2-hour surgery, and it is under general anesthesia. It's outpatient, but it's important to make sure that the patient is healthy enough for general anesthesia. And, age plays a part of that, but I'll tell you, I've had healthy 93-year-olds do just fine. And I've had some people in their 60s with a lot of health problems where it's much riskier for them. So we have to look at, what other medical conditions the patient has, make sure that this surgery is a reasonable risk for them. And sometimes that means getting their cardiologist involved or other specialists involved to do preoperative testing on them. And then the pneumonia vaccine, many of you have probably had the pneumonia vaccine, but that is recommended for anybody getting a cochlear implant because it helps vaccinate against one of the most common bacteria that cause ear infections. And so it helps decrease your risk of ear infections and meningitis that can occur if a patient with an implant gets a very bad ear infection. They have a higher risk of meningitis from that bacteria. So we always recommend that vaccine as part of the preoperative workup. And then the surgical procedure itself, like I was saying, is about 2 hours of anesthesia. This is a picture of a typical incision placement for a cochlear implant. The incision is behind the ear. And this incision usually heals very well. This is not a particularly painful surgery. Recovery from the surgery itself is not particularly difficult. It does need to heal for about 3 to 4 weeks before we can activate the implant. And that's because of swelling that can occur. You probably can recall on that photo, there's a magnet, and the magnet is what holds the processor on. So if this tissue is very swollen, the magnet can't hold on. So we have to wait for the swelling to go down before we activate. Typically nowadays, I do these procedures in a surgery center. Occasionally we'll do it at the hospital if the patient has more health problems, but it's an outpatient surgery at the surgery center and patients go home afterwards. The risks of surgery, talking about risks is always scary, but it's important to know what could potentially happen. So infection and bleeding are risks with pretty much any surgery you do. Dizziness, I'll say with adult cochlear implant patients is probably one of the more common things that I see is they have a higher risk of feeling off balance or dizzy for the few days after surgery. And that's about 20% of my adult patients will have some temporary dizziness. That is not typically long lasting or even particularly severe, but especially if they have some pre-existing balance problems, it's something we talk about because they need to be prepared for that or have somebody at home that can help them while they're recovering. Facial nerve weakness, the nerve that moves your face travels through the ear. And in order to place the implant, I have to drill some bone right next to the nerve. So I always use a monitor, which helps let me know if that nerve is being irritated by anything I'm doing. That risk is very, very low because the technique and the monitoring really decrease that risk. But we always talk about it because that nerve is there and it's right next to the cochlea. With regards to that, some patients, when their implant gets turned on, they can sometimes have some stimulation of that nerve with sound. Like they'll feel a twitch in their face when the sound comes through. And that's an easy fix. We can turn off 1 or 2 of the electrode contacts in the cochlear implant, so it will stop doing that. But that's because that nerve is right next to the cochlea. Loss of residual hearing. That is a risk with any cochlear implant. When we put the implant into the cochlea, if you still have some hearing in that ear, you may lose that hearing. The purpose of the implant is to give you better hearing when you're wearing the processor, but we typically try to do everything as gently and atraumatically as possible so that patients do preserve some sound awareness in that ear, which can be nice when you have your processor off, to still have some awareness of sound, but that loss of that hearing does occur in, a good amount of patients, depending how much hearing they have left. So we always talk about that, especially because during that 3 to 4 week period after surgery, before you can turn on your implant, it can be a little challenging if you do lose your residual hearing. You can't use your hearing aid during that time, and it can be difficult for patients. So they need to kind of be prepared for that. Implant malposition, the position of the implant, we do verify at the end of surgery. We do some intraoperative testing to make sure the implant is correctly in place inside the cochlea. So this is pretty uncommon actually, but it can happen. Also just placement of the magnet itself. Sometimes over time, the magnet can sometimes come down with gravity, and if it's too close to the ear, patients will want it, kind of revised or repositioned. That can all be fixed, and it's pretty unusual, but those are things that can happen. So if you're a patient with hearing loss, when do you consider this? Kind of the biggest thing is that you're really having a lot more trouble functioning just in day-to-day life with hearing aids alone. And I've had patients come in who have been using their smartphone for voice to text for 2 years before they've even been sent for a cochlear implant. And that is tragic to me, because that is a very difficult way to live, where you really need everything written out for you. And those patients are usually thrilled when they get their implant, because it's completely life-changing. But one of the things we in particular look for is when you do your hearing test and they do the word testing on you, if you're not deciphering those words, even if you can hear that sound at that level, but the clarity of the sound is very poor, those patients really can benefit from a cochlear implant, because the cochlear implant can give you better word recognition or better speech clarity. The hearing aids really, for the most part, are amplifying sound, and they're amplifying it in specific frequencies, but it doesn't do anything to really make the sound clearer. And so if you've really developed some problems with the processing of the sound in the cochlea because you don't have as many nerve cells in there anymore, the cochlear implant can really be helpful. So that's another thing we look at on the hearing test. You do need to have tried hearing aids and been wearing hearing aids. And the patients who do the best with the cochlear implant are patients who have been wearing their hearing aids consistently, and because that's still been stimulating their brain and their auditory nerve. It's actually a contraindication to an implant if a patient has been deaf in one ear with no hearing aids, no amplification for 30 years or more. We do not recommend an implant, because at that point in time, we know that the brain that corresponds to that ear has lost so much auditory processing capability. They're typically, like, best case scenario, they might get some sound awareness with an implant, but they're never going to understand speech in that ear with an implant. So we typically don't recommend an implant for that situation. So like I have friends, I have patients who maybe lost their hearing as a child in one ear, and they never had any sort of hearing aid on it. They never did anything with it. And then as they got older, they lost just age-related hearing in their good ear. And those patients, it can be a little tricky because their deaf ear is not a great candidate for an implant. And so oftentimes we have to wait actually until their good ear is at a point where the hearing aid is just not good enough, and we actually implant their better ear, because they would get a much better result in that ear because the other ear has been deaf for 40, 50 years. Cognition is important. Patients with advanced dementia who really, you can kind of tell if they can't operate their hearing aids very well, they're going to have a really hard time operating the cochlear implant. And so that can be a challenge for for patients who probably would really benefit from hearing better, but they do need to have a certain level of ability, dexterity, some familiarity with hearing aids and technology to really get the most out of getting an implant. And the patient has to be motivated for it. It is not a put it in and flip a switch and everything's perfect. There is a lot of practice after getting your implant. You have to practice listening with the implant. And for patients who have a hearing aid on the other ear, a lot of times that means actually taking their hearing aid out and spending some time every day just hearing with their implant, because that forces their brain to get used to the implant, and they will do better much more quickly than if they still just kind of always rely on their hearing aid ear. So patient has to want it, you know, I never force these on anybody, you know, but for patients who are motivated and really want to get a lot out of it, it's sometimes amazing how quickly they can adapt to the implant. And then we talk about bimodal versus bilateral cochlear implants. So bimodal means that you have an implant on one side and you're using a hearing aid on the other side. And that's probably the majority of my adult patients. We will implant their worst hearing ear and keep a hearing aid on the other ear, and they will be a bimodal hearing patient. If both ears are just so far gone that the hearing aid is doing nothing for them at all, then sometimes we will implant both ears at the same time. That's more unusual. That's much more common in children who are born deaf, to have bilateral implants put in concurrently. But there are some cases where we do that. And then the post-operative rehab, we're kind of talking about this already, but because it will be activated about 3 to 4 weeks after surgery, depending on the swelling. And then what we call mapping is the programming of the processor. And that's done with the audiologist. Just like they would program your hearing aid, they program the cochlear implant. It's like a little computer. And so they will do an initial mapping when they activate it. And then they will typically have you come back several times in those first 6 months to adjust the mapping as you acclimate to the implant. You need to practice listening with it. They give you special listening exercises to do. And during that first year, you usually see a pretty steep improvement in word recognition. And some things are more challenging and do take more time, specifically music appreciation, and then performance in background noise situations. Those two things are a lot more complex from a hearing perspective and can take a lot longer to get used to with a cochlear implant. But I'm always very happy when I talk to my implant patients and they tell me that they can use a phone on their implant ear. To me, that's a big success. If you can talk on a cell phone on your implant ear and understand the conversation, that's usually a huge improvement for these people. And so that's kind of a real world litmus test that I oftentimes ask them if they're able to do that. So a lot of patients ask about cost. We're probably all aware that hearing aids can be very expensive. And from an insurance perspective, insurances categorize hearing aids and cochlear implants completely differently. Hearing aids, a lot of times there's not very much coverage for, depending on your insurance plan. But implants are considered a surgical prosthesis. So they are covered by medical insurance. And we just have to show that the patient is an appropriate candidate, and it's typically covered just like any other surgical procedure would be covered. Medicare does cover implants. The tricky thing with Medicare for patients who are asking about a bilateral implant is that Medicare does not expressly cover bilateral implants, and they have no pre-approval process. So most of my Medicare patients do not want to even risk, having a denial on that because it's a very expensive implant. And so we usually do one implant But some other insurances do pre-approval. And so if we're considering a bilateral implant, we'll usually submit for that ahead of time and make sure everything's approved before going forward. And then the outer processor, that's the outside part, that usually needs to be replaced or upgraded about every 5 to 7 years, very similar to hearing aids from that perspective. And there is usually coverage for that within that time period. And most patients do, when they get an implant, they usually get a 2-processor system, so they have a backup. And so that's really nice as well, because if one processor is broken or is charging, they can use their other processor. And so the coverage in general is much better than it is for a hearing aid. And then some long-term considerations, there's really no activity restrictions if you have a cochlear implant. Obviously, if you get hit in the head where the implant is, it can damage the implant just like it can damage your head. So, but outside of head trauma, the implant usually does very well. Implant failure is extremely rare. It can occur, and every implant company, a lot of patients ask me like, well, which one's the most reliable or all that. Every implant company has had one major recall in their history. And every time that happened with any of the companies, they did cover all the expenses for patients to have their implant removed and a new one placed. Not just the device, but the surgical costs as well. So I will say the implant companies do a very good job of supporting their product. And usually have very good coverage if there is any sort of problem. And all of the companies do have really good just support in general, as far as if you're having a problem with your implant, if you need help, that 24/7, there's always online availability to chat, like online chat, or phone numbers that you can call as well. So they have really good patient support overall, all 3 companies. And then the internal component, that's designed to be lifelong. We put these in babies and they are expected to be there their entire life. There's no battery in the internal component, so there's no changing out batteries or anything. That's all on the outside part. So, and those are typically, you charge them. They're usually rechargeable. And then the current implants, this is actually very exciting. Just over in the last couple of years, current implants are now MRI safe. Whereas before, if you had an implant and you really needed an MRI for something, we would actually have to do a procedure where we would remove the magnet that is in the internal part, send you to go get your MRI, and then come back and put that magnet back in. It's a minor procedure, but logistically is kind of a nightmare. And so the fact that now patients can have an MRI with their implant with the magnet still in place is really impressive, and has made it a lot easier on patients who might be being monitored for a brain tumor on the other side of their head or other issues. If they have a chronic issue where they know they're going to need an MRI, that used to be kind of a barrier for them to consider an implant, but now they can do that. So that's been a really exciting change over the last couple of years. And so just in conclusion, I think we all know hearing is a major quality of life issue. And if your hearing aids are really not adequate, cochlear implantation, I've really seen it improve some patients' quality of life dramatically. They become more independent, partake more in their social life, which is really great. And our well-being is really directly linked with our ability to be social and communicate. So I think this is really important for patients to know that it is an option for them if their hearing aids just really aren't doing it. So at that point, I'd like to open it up for questions. And
okay, Dr. Balaker, please look at the chat box. You have a message. Okay. And so let's address that first, but it's kind of a long question with a little. Okay. Take a look. I think
this is from Liz Baker.
Yes.
Okay. All right. So do you want me to read this so everybody knows what we're talking about, or can other people see it?
Sure, so that everybody understands what you're answering. Yes.
Yeah. So Liz is saying, she's 83 years old and very healthy. She has a conductive and then subsequently also nerve hearing loss, which was noted a long time ago, back in 1948. Sounds like she had surgery in 1965 with a stapedectomy on the left ear. And still don't know what type of wire they put in. If it was in 1965, it's very possible it could have been one of the stainless steel ones. And then she was told she can't have an MRI for that reason. Yeah. And then also profoundly hearing impaired in the right ear and severe in the left. And then you had a glaucoma surgery for severe glaucoma, which makes things even more complicated when you can't see well and you can't hear well. So, from what you're describing as far as considering a cochlear implant in the right ear, no, I have had patients who have had a similar situation. They've got very advanced otosclerosis and they end up getting a cochlear implant. And so that is definitely something you could consider. And then the music, the music, like I said, it does take longer, but I actually had a patient, he was very much into music, and he went to a symphony concert like 3 months after his implant, which I thought was way too soon, but he said that he was able to enjoy it. So I definitely have patients who are able to enjoy music with their cochlear implant. And then this third question, if number 2 is iffy, if you remove your cochlear implant, independently remain hearing and enjoy music after. So it's a good question, removal of implants. We typically do not recommend removing an implant unless there is an actual medical problem. Removing the implant is not going to change your hearing. Once we put the implant in, you may lose residual hearing in that ear. That's a possibility. But if you're talking about wanting to just listen to the music with your other ear, what you can do at that point is just take the processor off on your right ear. And so that implant's not going to be doing anything, and you would just be listening with your other ear that's using a hearing aid. And so that you can certainly do. And some patients do find that for music in particular, they may prefer to do that if they don't like the way the music sounds with their implant. Hopefully I answered your questions.
Okay, so Ken Post, you have a question. I'm going to ask you to unmute and you can ask your question.
Oh, I was just wondering how long the external part lasts on a charge.
The external part lasts on a charge. Is that what you're asking?
Yeah.
Yeah, usually it typically will last all day and even longer, sometimes 2 days. It depends on the particular model of the processor. Different companies, there's some differences there. And those are really great questions. When patients are considering an implant and they meet with the audiologist for that testing, the audiologist does go over all the stuff about the processor with them. They pick out what color, talk about rechargeable, whether you want the kind on the ear or the kind that sits behind. And so they do all of that as part of the preoperative testing and consultation.
Do they have any Bluetooth capabilities?
Yes, they do.
Okay, Arlene Patton, would you like to unmute yourself and ask your question? And then Nancy Holloway will be next.
My question, Doctor, is that I am a patient at USC Keck, and also here, and they are not, as recently as 3 months ago, allowing people with cochlear implant to have an MRI.
Yeah,
I'm really confused about this because I have medical issues that say I do have to have an MRI occasionally.
Mm-hmm.
but I also need a cochlear implant, and I have seen Dr. Balaker, but I'm kind of on the fence about what I should do. So explain to me
that
where
is,
I can get an MRI then, I guess.
Yeah, I have encountered that with some imaging centers where they give a big pushback because this is such a new change to the implants. And even though the patient receives a card for MRI that says they are okay to have it up to a certain MRI strength, the current ones that I'm talking about are approved for both 1.5 and 3 Tesla MRI, which are the 2 most common types that are done. There are some like super higher resolution MRIs that are done at some medical centers, usually university hospitals, but that's typically only for very specific reasons. So I think we're still kind of in that transition where some of these imaging centers are still concerned about liability. If somebody has an older implant or whatnot, that it could negatively affect the implant. But the implant companies did all these studies and got this approval for this particular reason. So I understand that there's still some pushback out there from some of the imaging centers. They don't seem quite as familiar with the newer implants yet.
Let me follow it up with another statement here. I had a stroke 2 years ago, had an MRI at my local hospital. But when I went to USC Keck and saw the stroke neurologist there, he said the MRI wasn't, what's the word I'm looking for, detailed enough? So is that what you're talking about when you say?
Yeah, it may be that the level of detail that they want to do for your MRIs is higher than 3 Tesla. That is pretty unusual, but that might be part of the issue. The other issue is that if the area that they need to see in your brain is very close to where the implant would be, even if it's safe for you to get the MRI, meaning that it's not going to displace your implant, it still does create some distortion in the image around that area. And so that could also be what they're considering. If they need to see very fine detail of the area where on the same side as where the implant would be placed, they may not be recommending it because even if they can do the MRI, it's not going to look as clear if there's the magnet there.
Thank you.
Yeah.
Nancy Holloway, you asked to unmute and you can ask your question.
Hi, thank you for taking my question. It's about the Unibody system. Could you tell me a little bit more about that? Our son is going to have a cochlear implant, so I'm trying to get more information.
Yeah. So the Unibody system, it first came out a few years ago. And when it first came out, it wasn't as recommended because some of the directional microphones on it weren't quite as good for helping with sound localization and background noise. The newest version, at least with Cochlear, I'm honestly more familiar with their products because most of the implants I do are Cochlear America's company. So theirs is called they've got the Unibody, the Canso, that's what they call it. Medell also has one, they call it the Rondo. So the new Canso with Cochlear now has multiple directional microphones on it. And so it's performing just as well as the on-the-ear version in background noise and sound localization. So at this point in time, there's really, from a performance standpoint, there's not much difference between those two. And so I am starting to see more patients now select the off-the-ear option. So they can, it's a little more streamlined and, not going to sit on their ear, especially if they wear glasses. So now they're more equivalent now, but initially when it came out, the on-the-ear one from a sound perspective was still a little better.
Dr. Balaker, so that we can all see each other, could you stop your
Yeah, thanks.
Great. Okay. So the next person is Alan Katsura, and then Anne Mundell Noel, you'll be afterwards. You there, Alan?
I'm sorry, I have the mic off. Let Ann go first.
Oh, okay. Anne?
Hi, Dr. Balaker. Thank you for the presentation. I think it was very helpful for people to see all that is involved. My question or comment would be, could you please address the amount of oral rehab and therapy that is needed after the implant in order to maximize performance, so that patients recognize that there is a lot of work to it, and it's not just a switch that automatically the brain knows what to do with all that sound?
Yes, yeah, that was some of the stuff I was talking about with having to really practice with the implant. In particular for bimodal patients, if they have a hearing aid in the other ear, they're usually going to be recommended to, at least on a daily basis, spend some time with the hearing aid off, so they can really practice listening just with the implant. It is a process. It is definitely not a switch that you turn on and everything is perfect right away. And initially it can sound quite strange. A lot of people say that it sounds more electrical, more robotic sounding. Certain frequencies can sound off, and that's why it's really important to follow up with your audiologist and do those repeated mapping appointments, because they can adjust that based on your feedback as to what things are sounding like. But it is definitely not something that is just plug and play. And that's why we talk about patient motivation, because if the patient's not motivated to do those listening exercises and really practice with it, they're just not going to get as much benefit as they could be getting from it. So it's really the portion that you do with your audiologist, and they really do the heavy lifting on this because I put the implant in and make sure everything looks okay, and then but they see their audiologist a lot, and really should have a good relationship with them. And so from that standpoint, going to somebody that is accessible and you're able to get there and you're not like driving really far away is obviously much more preferable. And I think patients do better when they are being treated more locally and they can go in and have more adjustments and spend more time with their audiologist. But yeah, that's a very big component of getting an implant, is all that happens after the surgery. I usually tell patients surgery is the easy part. They're always worried about the surgery, but most patients are actually surprised how easy the surgery was for them. But it's that adjustment period that sometimes takes longer than they think. And it can be, especially if they're used to the way their hearing aid sounds, if they're expecting it to sound just like how their hearing aid did, it can be a little bit of an adjustment there.
Thank you.
Yeah, absolutely.
Okay, Alan, your turn.
Okay, I got several things here. If somebody else has anything, just interrupt me and I'll stop. First of all, I heard that, or I was told that the new off-the-ear processors are not coming in with telecoils.
Yeah, that varies between the companies. And I know that I've had other patients ask me about that. My understanding is it still does not, but I would have to verify with my audiologist whether the newer Canso does or not, because they did just change that. But that is a good question. I can ask them if there's a way I can follow up with any of you guys. I can maybe answer that question for you, or send something to Tony to answer that in particular.
I mean, I'm sure we could go to the website to find out. It's just that I was talking to my neighbor who is going through the possibility of upgrading, and she wasn't sure which way she should go. And then she did state that she was told that on the off-the-ear one was not able to use a telecoil.
Oh, okay.
And this was a cochlear.
This was cochlear? Okay.
Yeah.
Oh.
Is there a way to diagnose for auditory nerve damage before implantation?
So that's a good question. Usually in adults, we would be aware of that because there would have been a tumor or something happened in the brain. In children, some children are born, with, basically atrophy or aplasia of the auditory nerve. And so that's something that we'd look for on MRI in children for actual absence of the nerve or a very, incredibly small nerve. So that's usually how we look for that. If you're talking about just kind of loss of neurons and not actually an anatomic change in the nerve, that can be more difficult to assess. We're usually seeing that that's reflected in the word scores on your hearing test. So if you get very, very poor word scores, we know that the brain and the auditory nerve are not functioning that well. But a lot of times that has more to do with the nerve cells in the cochlea itself versus the auditory nerve. So most of those patients do still do well with a cochlear implant. It's really only a contraindication if there's an anatomic problem with the nerve or the brain.
And then, is there any delay if you're bimodal between the devices?
Not so. There really should not be a delay because the ears are, they're functioning independently. Having a bimodal hearing aid that communicates with the implant can sometimes give better performance. And that's mostly considering like background noise performance and sound localization. But no, there shouldn't be like an offset or delay there in when the sound reaches the brain.
Yeah, because all this stuff relates to my mom, who's bimodal, and she's 97, so she's not going to have any other surgery on it. But she had an infection that migrated to her implant.
Oh, wow.
And as a precaution, they decided to remove the implant.
Oh, wow. Okay.
And then now she says that she thinks she hears a little clearer in her hearing aid.
Huh.
Which gave me that idea that maybe there was some sort of, delay or something that was causing her a little confusion.
Yeah, I wouldn't expect so. What's probably happening is that, her brain's not having to integrate two different types of sound. And we do see that in particular, patients who have single-sided deafness and get a cochlear implant. And this is not very common still, but there are patients where if they suddenly lose all their hearing in one ear, they may get implanted. Their rehab is actually usually longer because they have their normal hearing ear as a comparison constantly. And it takes longer for their brain to kind of integrate those two different types of sound because they're really used, they've got a normal hearing ear on the other side. So there may have been something going on there with your mom as far as the way her brain was kind of processing the two sounds. It can be hard to know exactly. There's so much we still don't understand about the auditory processing that occurs in the brain itself.
Okay, thank you.
Yeah. You're welcome.
Okay, Randy Belzer, you're up next. Would you like to unmute yourself and ask your question? Randy?
It's really Gail that's asking the question. Hi, my name is not on there.
Right.
Hi,
Not yet.
Doctor's wonderful presentation. Really, really good. I've seen a lot. I had my surgery done about 8 years ago by Dr. Jalilian.
Yeah, I know him.
Fabulous. And I was unaided in this ear for 40 years. It took me about a year, but it still did well. I'm doing wonderful.
Right.
I'm just wondering, you said you needed an upgrade. That's pretty much a choice. I'm doing so well with my N6. I have a Cochlear America, and I'm doing well. I love the all-in-one, but I really want the T-coil. Why is it necessary to get an upgrade?
It's not a must do. It's usually dependent on, a lot like when you buy a new cell phone. How many things have they changed in the processor since your last one? And yeah, the N6 is a very good processor. So yeah, it's not a have to upgrade situation, but most patients, if they've changed enough things with either the sound processing algorithms or placement of the microphones, sometimes there's changes to it that allow you to wear it in the water, things like that, patients will choose to upgrade. And that's usually when you become eligible for upgrade.
Right, just so people know they can stay with the same
one absolutely.
A long time.
Yeah, especially if you're taking good care of it, which it sounds like you are.
Not really, but it's made very well. I tried.
That's good. That's good.
Right.
Okay, I put my hand up because I just want to make some comments. I have a Med-L cochlear implant. I was told from the very beginning that I could have an MRI, and something came up, and the doctor wanted an MRI, not necessarily of the implant. It didn't have
not of that area. Yeah.
Okay. So I made the appointment, fully explaining the limitations. That's the 1.5 Tesla implant. X-ray or MRI. And they said they were ready for it, and I backed out. Because, well, the worst thing that can happen is it pulls the array, pulls it out.
Yeah.
And everything. So, but I also understand under emergency situations, you would remove the implant, do the MRI, and then come back and reinsert an implant. You wouldn't do the same one, obviously, but you would do another one. So what's the likelihood of that happening?
So what happens in that situation, Tony, is you're actually not removing the implant. It's only the magnet, and the magnet is like it's like a quarter, and it actually can pop out of the body of the implant. So when we do that, we actually just make a little incision up over the magnet, and it can be done even under local, actually. And you take the magnet out, you slide the magnet out, and you keep it in a sterile container and put some disinfectant on it, and you put a bandage just over that area while the patient goes to MRI, and then they come right back to the procedure room, and you put it back in and put some stitches there. So we actually don't touch the array at all, because I've done surgeries due to implant failure where we've had to change out the implant. And when you slide that array out, the cochlea forms scar tissue around it. And so it's almost like this floppy scar tissue tunnel. And so you slide out the old one and put the new one right in, because that stuff will just collapse in, and it can be very difficult to put a new implant in if you don't do it immediately. So yeah, when we do the thing for the MRI, it's just the magnet. It's not the entire body or the electrode array.
Okay. There's another comment I want to make. I am a huge telecoil user.
Mm-hmm.
And I use, a neck loop. I used Clear Sounds for years and years. I still have it, but I'm now trying out, I think it's called Arco. And I'm trying out another one. So I listen to podcasts, music, whatever on my smartphone, and I use a lot. So here's my comment. I would never get a processor. I'd never get a processor that didn't have a telecoil. And number two, I would never get the single unit processor because you can't get enough power. You need to pull the neck loop. It has to be closer to.
Oh, interesting.
Now, I had some adjustments made on my processor, behind the ear processor, to work with the telecoil even better, but I could never get that adjustment for I had a Rondo. It's
Okay.
called a Rondo,
Yeah.
but it's the first one. It's the older one. But I would never be able to use that with a neck loop.
Mm.
Now, and also people would have to try it in a hearing loop. So, which I have not done. The hearing loop. Yes. So in Laguna Woods, most of the clubhouses I've had looped.
Mm-hmm.
No. So hearing loops or telecoil is really important. So
That sounds like it.
use a processor that does not have a telecoil. I think it's a sin.
Yeah.
That's my personal opinion.
Oh, no, that's a really interesting perspective. And I really like hearing from patients, it's all this day-to-day stuff that, as a surgeon in particular, I don't run into. And so I'm always kind of fascinated to hear from people, what kind of things they run into in their day-to-day life. And I know the audiologists really, they're experts on that, but thank you.
We do actually have in our audience some cochlear implant wearers, users, and let's see. I'm looking at the names here. Marla, are you here? I think she may have stepped away. Okay, we have Linda. Linda Wien,
I'm just saying I am.
like to make any comments?
Oh, Linda.
Okay, now let's.
Are you still speaking to me, Linda? Or are you talking to Gail?
Yes, I'm speaking to you, and
Okay.
I'm asking as a recipient, are there any comments you want to make about your cochlear implant?
Well, my clarity is horrible. Stop it. I'm very frustrated because of the clarity is not good, and my audiologist, which I will not name, has been mean and rude to me and said, your problem is your problem, I will not help you. And that I'm 80 years old now, and I don't understand all this technology. I'm trying to learn how to use a basic cell phone, and that can be frustrating, but it's fun. And I'm telling you right now, this meeting today has been very informative for me. I have really, really learned a lot of interesting things that I didn't know about. So I'm looking forward to future ones. But right now, the clarity is the big problem for me. I watch TV, I still have to use the closed caption. Telephone captions. I just get frustrated because my other friends like you and Marilyn, you're not having problems with your implant. You're hearing clearly pretty much. And I'm not. And that's frustrating. That's it. I don't want to take up all your time, but I just want to say this meeting has been super special for me.
Thank you.
Thank you, Linda. Gail, you wanted to make a comment?
I really want to just pass the word, and I've said this before. An implant is a miracle. It really is. And Tony, you're right about the T-coil and the loops. I listen to music, and it's like it just sounds wonderful. It's brought back so much for me. I grew up a hearing person, and then I went deaf. So this is a miracle for me. It is just, I can hear people behind their solid masks. I always tell them I'm deaf, just in case the battery goes out or something happens, so they need to know. But I'm like, I have to stop myself to say, and I want to thank you, all the doctors that are doing this type of surgery, because you're all changing lives for the better. I love my doctor. I told him he actually saved my life. When I lost my hearing, it's really, I didn't want to go on. And he gave me a new life, and that he never forgets that. And I never let him forget that. So, but I haven't one, I say I don't want another one. I'm not greedy. It's still a surgery, you know, those risks you said are still there. But if this ever failed or anything, I'm definitely open to getting another one. And do you work with certain insurances, doctor? Are you, can I be covered to use you? Of course, unless Dr. Jillian is not alive anymore, I have to go elsewhere. But how do you work with the insurance companies?
Yeah, I am contracted with pretty much every insurance company I can think of, including all the major HMO companies in the area, and then all the PPO and Medicare. So I haven't really run into a problem with, and we always go through insurance, and I do the surgery somewhere that's in network, and yeah.
Dr. Balaker, could you put your contact information or appointment phone numbers, that kind of thing, in the chat box?
Yes, I can do that.
Okay, that would be great.
I am gonna have to say goodbye soon too, because
yeah, we are going to say goodbye. Okay. Because, and I want to thank Joe Gale, who's our captioner, and she's been excellent this whole time. Thank you, Joe. Joe is from Chicago, so thank you, Joe Gale. And Dr. Balaker, thank you so much. It was, you know, I've seen a lot of these presentations, and I really enjoyed yours today, and I think I enjoyed you personally, so that makes a difference too.
Oh, thank you, Tony, and thanks for organizing this. Let me see. I hope this showed. Hold on. No, send. I'm not very good at the chat. Oh, here to everyone. That was the problem. It was sending it to somebody in particular. Okay. So that's the appointment phone number. If anybody wants to come in, we can talk specifically about your situation. And those are the office locations where I see patients. Head and Neck Associates is the group that I'm in. We have 12 different ENTs in the group, but I'm the cochlear implant one. So they'll only schedule you with me if that's what you're coming for.
Okay. Thank you so much. I think we're right at the end, and I hope to see people come back October the 12th to see Michelle Palowitz, research PhD from UC Irvine. She's going to have a fascinating program.
Okay. Thanks.
Thank you all. Bye-bye now.